you all for a nice and informative and definitely technologically smooth session yesterday. We had almost 300 delegates on Zoom and approximately 150 on YouTube yesterday. We hope to maintain the same momentum today as well and won't take much of time. Again, we will try to make this session and panel discussion more crisp and interesting. So Dr. Manas will definitely going to ask you a question for all the delegates, and you have to be attentive for this all the time. And today's session, yeah, okay. Today's session will be on pancytopenia, and we are all dealing with the cases of pancytopenia in our daily day-to-day practice. So I hope this session will definitely solve your maximum queries. And now, without taking much of time, let me introduce our today's faculties and speaker, Dr. Mahavir Tomar. He is our ex-secretary, North Delhi IAP. Hi, Dr. Mahavir. Dr. Harsh Srivastav. Hi, Dr. Harsh. Are you here? Dr. Lalit Maini and Dr. Shekhar Biswas. All these faculties are basically the pillars of North Delhi IAP, and without their support, we could not make this event successful. Thank you for being here with us. Now, it would be a great pleasure to welcome our dignified speakers and panelists. Our speaker for the today's session would be first topic, we will take approach to child with pancytopenia. And the speaker is Dr. Sunil Bhatnarayan from Bengaluru. And another thing is, after this lecture, we'll move towards the panel discussion on pancytopenia cases. And the session will be moderated by a dignified, renowned hematologist from Sir Gangaram Hospital, Dr. Anupam Sachdeva. Everybody knows him very well. So I welcome you for today's discussion, and it's a pleasure and honor to have you with us today. And panelists would be Dr. Sandeep Jain from Rajiv Gandhi Cancer Institute, Delhi. Hi, Dr. Rajiv. Dr. S.P. Yadav from Medanta, Gurugram. Hello, Dr. Yadav. And Dr. Vikas Dua is going to join very soon. Now, I think I should hand over the mic to Dr. Manas. He will coordinate with all of you. Thank you so much.
Hello, everyone, and good afternoon. So today we are going to talk about pancytopenia. We have done anemias, we have done bleeding disorders, and today we are going to move to pancytopenia, where all the three cell lines are involved. For the first talk, I have my dear friend, Sunil Bhatt. I'll just call him Sunil. Not only a colleague, he is my very dear friend. He was my neighbor when we were in Sydney together. And, he used to cook food for me all the time, and very delicious food. He leads the pediatric hematology, oncology, and BMT services at Narayana Hospital, Narayana Hridayalaya at Bengaluru. And he's a very dynamic person, and he's doing really well in this field. And we all look up to him for all the things that, he's doing in his day-to-day practice. So Sunil, over to you for pancytopenia. You have 30 minutes, and I'll just remind you by 25 minutes so that you can wind up in the last 5 minutes. The question answers will be taken at the end of the panel discussion. So that will be at 4 o'clock. From 3 to 4, we'll be doing the panel discussion. And you can type your questions not in the chat section, but in the Q&A section. We'll try to answer some of the questions by giving the answers then and there, because, we had almost 40-50 questions in the last 2 days, and some of them we'll be answering live at the end of the entire discussion. So over to you, Sunil.
Thank you very much, Manas, and IAP North Delhi for giving me the opportunity to be interacting with you today. As you said, we'll just be dealing with this section in two components. First is the didactic on how to approach pancytopenia, and then there'll be some cases to be discussed. It's a very basic presentation, and my focus is primarily on how to approach pancytopenia, not on the treatment aspect. So first of all, what's pancytopenia? Pancytopenia is drop in all the 3 cell lines, hemoglobin, platelet, and white cell. And it's very important to differentiate whether a single line or a multiple line is affected, because the differential diagnosis can be varied, and you have gone through some of them in the last couple of days, especially related to the red cell lineages. Sometimes, when you look at the CBCs very superficially, you may see there's one cell line which is low, but you have to sometimes look very carefully at the other 2 cell lines also, and there may be something in the other 2 cell lines also which may miss our superficial or a cursory eye. What's also important, which I'm going to highlight also, is that trends of counts are important. One single blood count may not be as significant as it would be how the patient has been behaving over a period of time. The severity of pancytopenia hasn't kind of been differentiated or defined very well as such, although we have some definitions with regards to aplastic anemia, which we're going to discuss later on. But we have a good, I would say, correlation based on the absolute neutrophil count, probably the most important cell line to get affected. And if it's less than 1500, less than 500, or profound, which is less than 200. And we have to remember that sometimes in pancytopenia cases, the lymphocyte count, both absolute as well as the percentages, may be well preserved, and that is something which should not mislead us. So how do these kids with pancytopenia present? As we would expect them, with low hemoglobin anemia and the manifestation of anemia, which is progressive pallor. Sometimes, it can be very sudden onset also, and the symptoms because of that, tiredness, fatigue, lethargy, and sometimes impending cardiac failure as well. Thrombocytopenia, bleeding, which can be due to trauma or sometimes without any trauma, especially in the mucosal and the cutaneous surfaces. Neutropenia is, as I said earlier, is a very important aspect of pancytopenia. It may be sometimes mild, it may be asymptomatic if the neutropenia is quite mild, but sometimes these patients can present with neutropenic fevers or febrile neutropenia, which we all know is a medical emergency. Now, what are the differentials, if a patient presents pancytopenia, what are the differentials which we need to consider? It can be a marrow pathology. It can be something which is related to the bone marrow itself, like inappropriate production in B12 deficiency. It can be infiltration from outside, like malignant infiltration, or sometimes benign infiltration also into the marrow. There can be a primarily stem cell pathology, that means stem cells are not working appropriately, like in inherited bone marrow failure syndromes. The marrow can be suppressed by chemicals or viruses, and sometimes can be immune dysregulation or destruction, like in HLH. Sometimes pancytopenia may be also because of peripheral destruction. So that means the marrow is doing its job, but then the cells are getting destructed or destroyed elsewhere. And it can be immune mediated destruction, or it can be sequestration outside the bone marrow. So these are kind of the broad differentials which we need to consider. From a pediatric point of view, infections are a very, very important etiology for pancytopenia, and a lot of viruses, the most common being CMV, EBV, HIV, and also the hepatitis viruses, sometimes tuberculosis and malaria, leishmaniasis, typhoid. These all can lead to pancytopenia as a manifestation, an important differential in a patient of pancytopenia. Now, there's another way of approaching pancytopenia, and that is on the marrow morphology, and I'll explain it a little later. When we go to the marrow aspirations, you can have a hypocellular marrow, that the marrow is not, cellular to the marrow is less. It usually happens in aplastic anemias or bone marrow failure syndromes. It can also help happen in virus-associated hypoplasias. But sometimes the marrow in pancytopenia can also be cellular. It can be a normal cellular marrow. Sometimes in MDSs and deficiencies like B12 folate deficiencies, hypercellulisms, sometimes infections also, the marrow can be cellular, or sometimes can be hypercellular also, like in leukemias. Sometimes in immune peripheral destructions, the marrow may become hypercellular. And so the message I'm trying to convey here is that marrow cellularity can be range from hypocellular to hypercellular marrow, and then still you can have a pancytopenia in the peripheral smear. Now, this is a question to the audience. There's a 12-year-old girl who's got was a known case of thalassemia major, She's on irregular transfusion and inadequate chelation. The chelation is deficit and folate, present with hemoglobin of 7, total count of 2 is 900, and platelet count of 82,000. On examination, she has thalassaemic facies, liver is 7 centimeters, and spleen is 12 centimeters below the costal margins. What is the most likely cause of pancytopenia in this child? The options are mentioned there.
So please click on the right option so that we can have the polling.
So if I see 80% of the audience has correctly answered this hypersensitism, that's a correct answer. So deficit rocks usually calfer or deferprone can give rise to cytopenias, but deficit rocks usually doesn't. Nutritional deficiencies unlikely, although folate deficiencies can manifest in as aplastic crisis, but that's what was deliberately mentioned. She's on folate already. And malignancy unlikely because there's already a diagnosis, and spleen is quite big, 12 centimeters. So probably she's got hypersensitivity and sequestration because of that. Now, how do we approach? Now, you've got a patient with pancytopenia coming to you. What are the things you're going to work this patient? How you're going to be coming to a diagnosis? Age, a very important thing. Age depends on the age of presentation. You can have, you lead to some specific cause of pancytopenia. A younger child, especially infant children less than 2 years of age, your bone marrow failure syndrome are high on the card. Older children, especially females more than 10 years of age, you have to seriously consider immune cytopenias, like in SLE and other collagen vascular disorders. So age is very important. Duration of symptoms and what symptoms they are having, pallor, bleeding. There can be fever for a long duration, which may suggest an infective cause or sometimes a malignant cause. Bone and joint pains are very common in malignancies, especially leukemias, and also in collagen vascular disorders. Rash, photosensitivity, again, manifestation quality. So it's very important to take a very detailed history. Drug intake, whether they are on some regular medications, and I show the list of medications later on, which can implicate into aplastic anemia or pancytopenia. It can be dose-related idiosyncratic reaction to the drugs. Past history of need for transfusions in this particular child, there can be some past history of similar manifestations. Family history is very, very important. Any other child in the family having similar problems, either of hematological disorders, blood transfusions, platelet transfusions, malignancy, unexplained deaths. And sometimes currently the patients may be relatively well, but there may be a recent history of viral illness, maybe few weeks or few months preceding the presentation. So a very detailed history is very important. We are pediatricians and we always need to, put a lot of stress on height and weight and the general physical examination, especially looking for congenital anomalies and stigmata of bone marrow failure syndromes. And I'll explain them a little later on what those are. So those are some things which we need to really put our effort on in identifying. So clinical examination, after taking a good history, a good clinical examination is also very, very important. First of all, we need to understand the severity of pancytopenia, how pale they are, how serious the anemia is. If they're febrile, whether this fever is because of the neutropenia because of pancytopenia, or it is because of the infection which is leading to this fever. Severity of bleeding because of thrombocytopenia. We also have to look at evidence of lymphoproliferation by a good examination of the lymph nodes all over the body. You have to look at the liver and spleen, size of liver and spleen, span of liver and spleen, and also the spleen, if it's large, how large is it? We have to look at features of other infections like Candida, stomatitis, exudates, which is kind of indirect, it can lead to a diagnosis. And knuckle hyperpigmentation in India, we still see patients with vitamin B12 deficiency present with pancytopenia. So a good clinical examination is very, very important, what I'm trying to say here. And I was telling you about the inherited bone marrow failure syndromes like Fanconi anemia and Blackford diamond, which I think you must have kind of gone through the last couple of days as well. So it's important when we see them, look for short stature, look for the facies, typical facies in Blackburn diamond, Fanconi. There are radial anomalies. There are thumb anomalies. There can be nail dystrophies, leukoplakia, skin pigmentation. All of this can be suggested of dyskeratosis, for example. These are all the stigmata, subtle signs, which K-yellow spots, because these are something which you very commonly see in Fanconi anemia patients. This is something which we need to look at a general physical examination. So when we have done a good history, a good general physical examination, we kind of get a clue whether this pancytopenia is transient or persistent. Has it been there for a long time, as a short duration? Pancytopenia does it look like a marrow pathology, or does it look like a peripheral destruction? And does it look like a congenital versus acquired pathology for the of this pancytopenia? So I think these are some of the things which we kind of get a clue, and our lab evaluation will be directed towards the clues which get on the physical examination and the history. CBC undoubtedly the most important investigation, and of course diagnostic investigation in pancytopenia. And as I alluded earlier, acute absolute neutrophil count does tell you about the severity of cytopenia and how low the neutrophil count are. Red cell indices, again, we kind of look at them very superficially, very accurately look at them, but they are sometimes quite helpful. For example, you've got a high MCV and high RDW, it can be such a nutritional deficiency like vitamin B12 and folate deficiency. If you've got a high MCV but RDW is normal, it is more likely to be a aplastic anemia, acquired aplastic anemia, or a bone marrow failure syndrome. So red cell index is very, very important. Reticulocyte count, it's a very important marker of marrow activity, especially in the red cell compartment. So if you've got a normal retic count, it means that the activity of the marrow is adequate. And we always find a low retic count, especially when there's a manufacturing defect in the bone marrow itself. Peripheral smear, again, very, very important, whether it's macrostic or normostic anemia, which I give an example of macrostic anemias, which can be nutritional anemias, or sometimes in the acquired aplastic anemia. You can have immature cells in the peripheral blood. You can have blast cells in the peripheral blood, which hypersegmented neutrophils, which suggest a vitamin B12 deficiency. So peripheral smear itself can give you a lot of clues on the probable cause of pancytopenia. Now, based on your history, physical examination, and the basic evaluation which you have done on the CBC, you may go ahead and do further specific investigations to find out the cause of pancytopenia. For example, if you're suggesting a collagen vascular disorder, ANA, double-strand DNA, DCT may be something worthwhile to do. Evaluation for tuberculosis and other viral infections. As I said earlier, it's EBV, CMV, hepatitis B are very common, HIV very common infections which can lead to pancytopenias. Vitamin B12 and folate levels may be required. And sometimes HB electrophoresis is the case. For example, I showed you was a case of thalassemia major, and it can be sometimes a intermediate, never been transfused before, and also may present like this. So HB electrophoresis may be sometimes required. HB electrophoresis is also investigation, where you check HbF levels, and those are high in some case of aplastic anemia, especially the ones which are inherited bone marrow failure syndromes. So that is the evaluation, or the lab evaluation you've done. So we can also kind of put the lab evaluation in this format. That means what we need for the confirmation of diagnosis of pancytopenia. Then we need something to assess the severity of pancytopenia. And then we need some evaluations to find out the primary etiology of pancytopenia. So a CBC and peripheral smear is a diagnostic. So it tells you there's pancytopenia, and bone marrow aspirate and biopsy are the ones which kind of diagnose the pancytopenia. It's a confirmation of pancytopenia, and I will go through them in the next couple of slides. Now the severity assessment, as I said earlier, neutrophil count and absolute reticulocyte count are the ones which tell you how severe the pancytopenia is. And then the evaluation of etiology. For example, you need to rule out bone marrow failure syndrome. So you can rule out secondary causes of aplastic anemia. And this table kind of gives you is again the same things we discussed in the previous slide. That was what are the investigations you'll go ahead to find out the cause of pancytopenia, viral markers. Bone marrow failure syndromes, you do an ultrasound to look at renal anomalies and other anomalies, echoes for heart anomalies, which are the other associated manifestations in Fanconi anemia, for example. Mutation studies may be required sometimes. Autoimmune evaluation, others, as I said, HbF, LFT, and HB electrophoresis. So this is workup for the etiology, and the other two workups are for the severity assessment as well as for the diagnosis. Now, bone marrow, as I said, is probably the single most important evaluation of pancytopenia. So, as we know, when we do a bone marrow examination, it's basically a bone marrow aspirate and also bone marrow biopsy. Now, aspirate is basically tells you, it gives a fair bit of idea on the cellularity, but it's more so required for giving you the morphology of the hematopoietic precursors. It can tell you that the precursors are less or more. It can tell you whether there's any arrest in maturation. It can tell you whether there's an abnormal, hematopoiesis going on, or there's some infiltration. For example, you have a patient of storage disorder, and there's a lot of storage infiltration into the bone marrow, and they can present pancytopenia. You can have infiltration of leukemia cells in a patient of leukemia, which again can present as pancytopenia. So very important evaluation, very important investigations, and gives you a very a good idea of the cause of pancytopenia. Now, bone marrow biopsy, on the other hand, again, it gives us idea about the cellularity of the bone marrow, and it is very important to quantify the cellularity of the bone marrow. And I'll show you later on why it's important. It also tells us about infiltration. Especially in a solid tumor. For example, in a patient of neuroblastoma, you can have, or any other solid tumor in a child, you can have infiltration of the bone marrow, which leads to pancytopenia, which may be missed on aspirate, but on a biopsy, there's a higher chances of finding this infiltration. It can also tell you what there's a fibrosis in the bone marrow. So there's a dictum: any patient of pancytopenia, if you're doing a bone marrow examination, it is always mandatory to do a bone marrow biopsy along with it, because one of the common mistakes we do, we take an aspirate, and then we are misleaded by aspirate. Always in a pancytopenia, this is one of the message I want to convey now today, is that always in pancytopenia, do aspirate and a bone marrow biopsy together. Probably not for this audience, but you can get a lot of clues on the bone marrow, which can lead to the primary etiology of pancytopenia itself. For example, hemophagocytosis may be seen there, which may be mentioned HLH. You may see megaloblastic erythroid precursors, which may be such a vitamin B12 deficiency. So your evaluation with bone marrow aspiration and biopsy may not only help in diagnosis, but also confirming the cause of pancytopenia. So hence, it's a very, very important evaluation to do. Now, I've got a second question for the audience. In case of pancytopenia, which of the following statement is true? Corrected reticulocyte count is always low. Corrected reticulocyte can be high or low. Reticulocyte count is low, but corrected reticulocyte is normal. And reticulocyte count is normal, but corrected reticulocyte is low. So if you could answer this in the next 20 seconds, then we'll go to the next slide. Okay, so we have got a fairly spread out answer here. So we got almost 1/3 people, 1/4 people answering each one of the 4 choices, and the one which is highlighted here is the correct choice. So I was trying to show you, we're tempted to say that corrected reticulocyte count would be low in a patient of pancytopenia, which is not correct, because I showed you in the previous slides that pancytopenia may not always be because of bone marrow failure. It may not be always because of bone marrow not functioning. We can have pancytopenia even when there is a higher peripheral destruction, and in those cases, the reticulocyte count can be even normal or high. So that's why the choice number 2 is correct here. Now, aplastic anemia is used synonymously with pancytopenia. So I'll say that all the cases of aplastic anemia are pancytopenia patients, but all the cases of pancytopenia are not aplastic, and that's what we discussed in the previous few slides. But aplastic anemia being one of the common things we see in our day-to-day practice, there are some definitions which are kind of laid down in aplastic anemia. And as I said earlier, pancytopenia is a little loose term. We don't really have cutoffs. But in aplastic anemia, there are definitely cutoffs. Hemoglobin of less than 10, platelet count less than 50, neutrophil count of less than 1.5. Either of the two, if you define it as aplastic anemia. And we do have severity assessment also. So if, for example, you have you have a non-severe aplastic anemia, wherein the neutrophil ANC is less than 1500, platelet count is less than 1 lakh, but bone marrow hypoplasia is there, but then it's kind of not that low. Cellular is not that low. In a severe aplastic anemia, cellular is less than 25%. That's why I was telling you earlier, bone marrow biopsy is very important to understand the cellularity. Neutrophil count is less than 500, platelet count is less than 20. So that's is a severe form of aplastic anemia. And a very severe form is all of this above, that's severe aplastic anemia, but neutrophil count of less than 200. It's just you don't need to learn this, but then we do have definitions in aplastic anemia. And if we just see this list here, severe and the very severe forms are the ones which lead to a lot of morbidity and mortality and need to be dealt on an emergency basis. As I said, relatively common pediatric problem. Males and females have equal distribution, and it has a biphasic distribution. So usually 10 to 25 is the first peak which we see. It can happen at any age, but usually in pediatric practice they're more common in children who are more than 10 years of age. Lot of factors and lot of etiology which has been suggested to aplastic anemia, being drugs, toxins, ionizing radiation, immune disorders, infectious agents. All of them can lead to aplastic anemia. And I was telling you earlier, there's a long list of drugs which can lead to aplastic anemia. There's a list here, and we need to ask this history when we are assessing these patients of aplastic anemia, and some of the common ones like anticonvulsants, antibiotics are the ones which are used regularly in pediatric practice, and we need to ask about that. We need to, some of the infectious agents which we discussed briefly in the last slides can also lead to aplastic anemia, and these are the list of those which can lead to aplastic anemia. And aplastic anemia is basically the mechanism of pathophysiology is multifactorial. It can be a direct damage by toxins to the stem cells. It can be immune damage or immune attack, which seems to be the most likely explanation in most of the cases. That's why immune suppressive therapy works in some of the aplastic anemia patients. And it can be also a problem with the microenvironment in the marrow, which can lead to, and the cumulative effect of all of them is that the bone marrow fails, and the manufacturing of the hematopoietic stem cells is defective. Now, how do we manage aplastic anemia? I don't, this is not for us to understand the full management, but I just want to give a little flavor. In pediatric practice, that means all the children, of course, they are less than 40 years of age. All children who have got severe aplastic anemia or very severe aplastic anemia, if they have a matched sibling donor, they need bone marrow transplant as a first choice of treatment. So the first line of treatment for children, if they have a matched sibling donor, is bone marrow transplantation. If they do not have a matched sibling donor, then you can consider non-transplant approaches, and that is basically immunosuppressive therapy with ATG and cyclosporin. So because severe aplastic anemia and very severe aplastic anemia are a medical emergency, that's why urgent HLA typing and referral is required, because if they have a matched donor, they should proceed to transplant ASAP. Now, from a pediatrician's point of view, what other supportive care is required in a patient of aplastic anemia? They transfusions, anti-infective prophylaxis, growth factors. How do they manage when they come in the hospital? Vaccination. So transfusion, you must have probably learned in the last couple of days about how to transfuse a patient of thalassemia, but this is other way around in aplastic anemia. You try to keep a minimum hemoglobin level. We usually transfuse when the level is less than 6, but we usually do not transfuse when there is 8. Between 6 and 8, if they're symptomatic, then only transfuse. So the message here is transfuse only when it's symptomatic, and we let them be at a hemoglobin 6, 7, and if it's less than 6, then you can transfuse. Platelets, on the other hand, again, transfusion if this platelet count is less than 5 to 10,000. Only transfuse less than 20 if they're having bleeds or they're febrile. But if there's significant bleeding, then of course platelet count of any platelet count, you need to transfuse them. We should not transfuse for later family donors, mothers, fathers, brothers, sisters, immediate cousins. Should not transfuse for them. Leukodepletion is recommended for all these transfusions they get, and if possible, irradiate the blood products because it can lead to transfusion-associated graft-versus-host disease, especially in transplant patients and especially the patients of aplastic anemia who have received ATG therapy. In those patients, try to give irradiated blood products. Now, what about anti-infective prophylaxis? So we are tempted because they're aplastic, they have got low white cell count, they have high risk of infections. We are tempted to give prophylactic antibiotics for them. There hasn't been shown a significant role of prophylactic antibiotics. It may lead to resistance bugs. So most of us, we do not give any prophylactic antibiotics to these patients. Septron and
can be
5 minutes.
Yeah.
Yes. Septron and antiviral prophylaxis is again is given to the post-transplant patient, but not otherwise in patients with aplastic anemia. However, antifungal prophylaxis is what should be given because the neutrophil count is low, especially the patients who have a neutrophil count of less than 0.2, and antifungals, especially voriconazole or posaconazole, which are called as anti-mold agents, should be used as prophylaxis. Growth factors like GCSF or erythropoietin do not have any role. They can be sometimes used in a short term, especially those who are sick, febrile neutropenia patients, but they do not have any role in the management of patients with aplastic anemia. Vaccination, from a pediatrician point of view, age-appropriate vaccination can be given, but the response can be inadequate. We should try to avoid live vaccines during this period because they may either undergo transplant or undergo ATG therapy, and they may not be safe to be given under those situations. And the patients who undergo transplantation, their vaccination guidelines are different and are not in the scope of this presentation today. So what's the prognosis of aplastic anemia? If bone marrow transplant is used as upfront treatment of those who are matched sibling donors, 75 to 80% can be cured. And in immunosuppressive therapy, 40 to 50% can be cured. So that is why I was alluding earlier, we should make an attempt to identify a donor for them, matched sibling donor, refer them early, and have a bone marrow transplant because that gives them the best chance of cure. And younger children, we know the children who are less than 16 years of age, they do better than the older children or adults. So in children, the outcomes are really good in a patient with aplastic anemia. Now, the third question which I have, this for the audience, 11-year-old boy present with hemoglobin 5.6, TLC of 1100, platelet count of 7,000 and high-grade fever. Bone marrow, aspiration biopsy and other workup suggest acquired aplastic anemia. What is the following what's the correct thing to do? So there are the options which are given there. So 20 seconds to answer this question, please. Okay, so we got the responses, and most of the people have answered this question correctly. About 70% people have answered the question correctly. So the correct answer is start antibiotics immediately because the patient has got severe neutropenia and has got fever. So it's a febrile neutropenia. It's a medical emergency. Hemoglobin is quite low. Platelet is quite low. So we need to stabilize the patient with blood and platelet transfusions. And if possible, do HLA typing and then refer to a higher center. That is the correct choice. Now, in a aplastic anemia patient, we always need to remember that there are other syndromes which are inherited bone marrow syndromes like Fanconi, Dyskeratosis, Schaumann diamond. These are the ones where aplastic anemia is there, but it's because of an inherited or a genetic cause. And it's very important to differentiate these from acquired aplastic anemias or idiopathic aplastic anemias because the treatment and prognosis are completely different. So Fanconi anemia, for example, the most common inherited bone marrow failure syndrome, they will have 75% of them will have some congenital anomalies, like I mentioned earlier, whether it's radial anomalies, thumb anomalies, skin anomalies. They can be diagnosed by chromosomal breakage study. Immunosuppressive therapy will not help in these patients. So that's why the only treatment for them is bone marrow transplantation. And that's why it's important to differentiate these from the patients of acquired aplastic anemia. This is just an example of Fanconi anemia, where you can see these thumb anomalies, example of chromosomal breakage study, which helps to diagnosis of these Fanconi anemia patients. The blood is exposed to either mitomycin C or diapoxybutane, and you see the fragility and the chromosomal breaking under the effect of those. So this is a diagnostic test for Fanconi anemia. We can do some other specific tests for the, for other diagnosis based on the lab suspicion. It's not the scope of this presentation, but lots of other investigations are available to give you a clue on the diagnosis. Now, today's date, we are increasingly using genetic testing, especially syndromal syndromal workups, or what we call as clinical exomes or whole genome sequencing, wherein you look for a battery of mutations known and some of its uncertain significance, one are with known significance. And these investigations especially help us in some borderline cases, where you may not find a very concluding evidence on the basic lab evaluations, and really help us a lot of patients. This is some of the examples of those patients wherein a clinical exome has really helped to figure out their genetic etiology, and can be used in some of the difficult cases to clinch a diagnosis. So with that, I will be concluding that. But before conclusion, there's one more question for the audience. So for a patient present with aplastic anemia, which of the following statement is correct? You should always rule out inherited bone marrow failure. You should rule out inherited bone marrow failure in those with family history. You should give a trial of treatment. Those who do not respond should have workup for inherited bone marrow failure. It really doesn't matter from the management point of view whether you rule out bone marrow failure or not. So 15 seconds for the answer, and then we'll discuss this question. Okay, so we have got a little bit, distributed response, but majority have answered the correct choice, and that is you should always rule out inherited bone marrow failure in a pediatric patient. And I showed in the previous example, although you may have musculoskeletal and other examination findings in patient of bone marrow failure syndrome, but that's only maybe in 70 to 75% of the patients. You may have still 20-25% of the patients who you may not be having an obvious examination finding to allude to inherited bone marrow failure syndrome. So you should always make an attempt to rule it out, because as I showed you earlier, the treatment options and outcomes can be really, really different depending on the type of bone marrow failure it's inherited versus an acquired bone marrow failure. So with that, I conclude. So in conclusion, what I try to discuss with you today is that what is pancytopenia, how we can to an extent help categorize pancytopenia based on the neutrophil count on severity. What are the workups required, and what workups required in terms of diagnosing pancytopenia, assessing severity, and then assessing the cause of pancytopenia. I also have been, I tried to discuss with you the role of bone marrow aspiration and biopsy in the case of pancytopenia, not only in diagnosing, but also sometimes giving you the definitive answer of the cause of pancytopenia. We also discussed the role of lab evaluation, especially the reticulocyte count and peripheral smear in evaluation of pancytopenia. We discussed aplastic anemia in a little bit more detail, and we try to discuss the non-definitive treatment options like transfusions, vaccination, chelation, anti-infective therapy, and also need for immediate management, HLA typing of patient of aplastic anemia, because these are the first-line treatments and maybe can make a lot of difference in the outcomes of aplastic anemia patients. And also try to discuss the role of the need of ruling out inherited bone marrow failure syndromes in a patient of pancytopenia because their outcomes and their management strategy are all altogether different. Thank you very much for your attention, and over to you, Manas. Thank you very much.
Thank you, Sunil, for a wonderful presentation. You have nicely set the stage for us to now move on to the cases of pancytopenia. The moderator for this presentation is none other than Dr. Anupam Sachdev. This man definitely does not need an introduction. He's the one who is responsible for most of us to be here today and doing pediatric hematology oncology in the country. In the panel, we have my teacher, mentor, Dr. S.P. Yadav, who is in Medanta Hospital. He heads the unit and is the chief of the bone marrow transplant program. Dr. Vikas Dua from Fortis Hospital, Gurugram, and Dr. Sandeep Jain, who is in Rajiv Gandhi Hospital. I think some audio issue. So Sandeep, Vikas, Dr. Yadav, and Dr. Anupam. Sir, over to you. Would you like to share your screen, Dr. Anupam? Dr. Dinesh, can you allow Dr. Anupam to share his screen?
Already allowed.
Okay.
Okay, am I audible now?
Yes, sir, you are audible.
Okay, fine.
Hello, sir.
Yeah, I'm fine. I'll just be there with you. Okay, friends, thank you very much, Manas, and thank you, North Delhi IAP, for inviting me for conducting this panel discussion. It's a pleasure seeing all the stalwarts, as I say, Dr. Yadav, Dr. Vikas, Sandeep Jain, Manas, Sunil Bhatt, all of you. It's a real pleasure seeing you on the same platform. So we move on to the panel discussion. The first case is a 15-year-old Hindu boy, predominantly vegetarian, had low blood sugar from 50 days, generalized weakness, easy fatigability, and pallor for 7 days. No history of cough, cold, rash, weight loss from any site. On examination, the child had tachycardia, pallor, mild icterus, liver was just palpable, spleen 1 centimeter below the left costal margin. And, what is your impression about it, Dr. Yadav? This was CBC,
Yeah.
hemoglobin 5 grams, 1900 was a TLC, platelets were 62,000, and so on and so forth. Could you please give your impression about this?
So as the CBC shows that all cell lines are affected. So this child has got pancytopenia. And with this pancytopenia, we see that there is macrocytosis So it's a macrocytic hypochromic anemia in this in the red cell lineage, which gives us a clue that it could be either nutritional deficiency like vitamin B12 or folate deficiency, or it could be aplastic anemia or myelodysplastic syndrome or something like that, where macrocytosis can be seen. So to distinguish the two, we need we need a retic count. So retic count should be low in both, and RDW and peripheral smear would help us. So here RDW is high, it is 22%. So usually nutritional anemias, your red cell distribution width is higher as compared to aplastic or myelodysplastic or leukemias, where it is usually on the normal side. So I would say that possibly this child might be having nutritional cause of macrocytic anemia leading to pancytopenia. Thank you.
So Dr. Yadav is absolutely correct. It looks like the possibility of nutritional anemia is very high. If the counts had been near normal, I would keep another possibility, and that is Evans syndrome kind of a situation where you can have a high RDW, low hemoglobin, a high MCV, and so on and so forth. But this looks like a nutritional anemia, and this is the peripheral smear. Could you please describe the peripheral smear, Dr. Sandeep?
Hello.
Sandeep,
Hello, sir. Can you hear me, sir?
Yes, yes, absolutely.
Actually, I'm not able to see the slide. Just
okay, then Dr. Yadav, could you please go on to that and we'll
okay.
test.
Okay, I can see now. I can see now. So, if I look at this peripheral smear, the RBC numbers are definitely decreased, and I can see some large. Although there is no small lymphocyte to compare with, but definitely there is anisocytosis. I can see some macrocyte. I can see some ovelocytes. Some of the RBCs also have increased central pallor. And in the center, I can see one neutrophil, which is definitely having 5 to 6 lobes. And I don't see any platelet. So I think it's a anemia with macroovelocytes, with hypersegmented neutrophils, and with decreased platelet.
Okay, so this is typically moderate to marked anisopoikilocytosis, normocytic, normochromic to microcytic cells, few ovalocytes, electrocytes, leukopenia is there, hypersegmented neutrophils, and platelets are reduced on the smear. So this is typically seen with macrocytic, megalocytic anemia. Although with the kind of microcytosis, I would put it still as a dimorphic picture with predominance of B12 deficiency. What other investigations would you like to do, Dr. Satya?
Yeah, so peripheral smear has already given us a clue that it looks like that it may be, there are macrocytes definitely there, and there is some anisocytosis there, and there is some microcytes are also there. So it's a dimorphic anemia, and we would like to get, and for whenever you have B12 deficiency, your bilirubin, you can have indirect hyperbil. So I will order a bilirubin direct and indirect, and there should be indirect hyperbil present. Plus LDH, we should order, and LDH is usually high. So that's what I will order. And there is an LFT rest. I would order maybe a serum ferritin also, to look at the iron status, and maybe serum iron if required. So these are some other basic investigations I will do, and then possibly a bone marrow would be required that would 100% confirm that this is a megaloblastic anemia or nutritional anemia, not a malignancy or anything else. Thank you.
Okay, the retic count was 2.78. Corrected retic count was 1.4%. As you said, LDH was high, 3,551. There was a total cerebral bilirubin of 2.13 milligram with indirect hyperbilirubinemia. OT and PT were normal. B12 was 110 picograms per ml. Folate was 4.07 nanograms per ml. Would you still like to do a marrow with this kind of a picture? Dr. Yadav?
This is very much in favor of megaloblastic anemia or nutritional anemia. So a marrow is not required in this child, and we can give a trial of B12 and folate. And if this everything corrects and the child responds, so I think it can be avoided. But if there is no response, then the marrow may be required.
Yeah, good. Would you like to do a bone marrow? Well, that's and if you do a marrow, what findings would you expect, Dr. Yadav?
So a marrow would show us a lot of megaloblast which would be present, and we should look for, whenever we are doing marrow in a pancytopenia, we should look for leukemia also, that there is no lymphoblast or myeloblast which are present. And we should also look for any evidence of hemophagocytosis, which may be a cause of pancytopenia. So we would look for all the other things also in the marrow. And a biopsy should also be done, which would tell us whether that's, if there is hypercellular marrow, an aplastic anemia can also be a DD. But megaloblast, if they are present, that would be in favor of nutritional deficiency. Thank you.
So it was a hypercellular marrow with megaloblastic erythroid hyperplasia, confirming the diagnosis. Now, what are the other causes of a hypercellular bone marrow, Dr. Vikas? Is he there?
Yes, sir. I can hear you, sir.
Yeah, please. Could you?
So we can see hypercellular marrow in conditions like MDS, in conditions like leukemia. We can have a hypercellular marrow in PNH. Definitely in megaloblastic anemia because of B12 or folic acid deficiency, we can have a hypercellular marrow. And in conditions in which you have an immune-mediated destruction like SLE, and if that's the cause of pancytopenia. In that case, you can see a hypercellular marrow.
Yeah, absolutely. So you can see primary bone marrow diseases like MDS, paroxysmal nocturnal hemoglobinuria, or you can see it secondary to systemic diseases like SLE, hypersplenism, B12 folic acid deficiency, infections, storage diseases like Gaucher's, Niemann-Pick's, alcoholism, sarcoidosis, although we don't see that much sarcoidosis in children. And you can see a hypocellular marrow in different other conditions. We won't go into the details, of course, because they've been covered very well by Dr. Sunil Bhatt. And an infiltrative bone marrow disorder can, although it looks hypercellular, but that is because of the infiltration, and that can also lead to a pancytopenic picture. How would you treat this patient? How would you monitor the treatment response, Dr. Vikas?
Sir, we can treat. So this is a case of vitamin B12 deficiency, a classical case of vitamin B12 deficiency. So we can use a parenteral preparation of vitamin B12, or maybe oral therapy can be tried for these patients. And if we treat these patients, then we would definitely like to monitor the response. So you will see some reticulocytosis happening 3 to 7 days after start of vitamin B12, and then your thrombocytopenia, which has been there for this patient, will resolve in 2 weeks time, and your hypersegmented neutrophils, which are there in the peripheral smear, that will also disappear in 2 weeks time. Your LDH will also normalize in 2 weeks.
So when, as you said, that you can do a supplementation with an IV B12 1 milligram, and then you monitor the response. And that's how we see the responses by looking at on day 1, we find that the, your serum iron and bilirubin may start falling on the day 1 itself. You find an increase in reticulocytes on day 2, and so on and so forth. And then we can monitor the patient. And of course, you can look at the retic count with the newer parameters which are available in the lab. Now we can easily monitor in 3 days' time as to what is happening and take a call on whether further things are. My take on this is that when you have a kind of a dimorphic picture Always start with B12, see the response for after 3 or 4 days, then add your folic acid and iron, because if you do it to all the things in one go, your B12 will not get absorbed and you may end up with neurological signs because of B12 deficiency. As the hematopoiesis comes up, the B12 will be further depleted and it will lead to precipitation of neurological signs. Okay, 2-year-old girl, fever off and on from 2 months duration, fever persisting despite multiple antibiotic courses, received Ayurvedic treatment for 15 days, had worsening pallor, lethargy, irritability. On examination was febrile, irritable, severe pallor, generalized lymphadenopathy, liver was 4 centimeters, spleen was 2 centimeters. CBC showed 4.3 hemoglobin, 2,320 count, 5,000 platelets, neutrophils of 3%, lymphocytes 90%, MCV of 87.7, RDW of 17.3, and RBC count of 1.38 million. Dr. Vikas, what is your opinion about this patient? Sorry, not Dr. Vikas, Dr. Sandeep.
Sir, this is like severe anemia. WBC is on the lower side. The neutrophil count are very low, 3%. Platelet count is 5,000. So it's like pancytopenia. So we should look at the peripheral smear, and also we have to go for bone marrow aspiration biopsy in this case.
Okay. Any other, I mean, you would like to do, but what is your differential kind of a thing in this case?
So considering the age of the child, she has hepatosplenomegaly, she had history of fever, and she had history of pallor. So definitely leukemic disorder is my first differential in this patient. Infiltration by some infiltrative disorder of bone marrow should be high on the priority.
Absolutely. I think we have to think of that, especially now that we have seen the MCV is low and there was lymphadenopathy also. So we have to start thinking this thing. How would you like to proceed? You have told us that you'd like to do a marrow in this case. Would you like to? Yeah, please.
Yeah, definitely after initial stabilization, we should do a bone marrow, and bone marrow. When we are doing bone marrow in a suspected case of leukemia, we have to take care that we have to take all other samples that we will later on require, like for flow cytometry, molecular and cytogenetic studies also. And in every case of pancytopenia where you're suspecting leukemia, you should also do bone marrow biopsy also, because sometimes your leukemia may not be very evident on the slides, and you may need more information that is required that may be useful from the biopsy point of view.
So this was the marrow of the patient. Comments, Dr. Sandeep?
So it definitely looks like the RBC numbers are low, and there are large atypical cells with high NC ratio, and typically they are looking like lymphoblast.
Okay.
Platelets are definitely reduced here.
Yeah. And, it was MPO negative blast by cytochemistry. So it looks like your ALL kind of a situation.
Yeah.
Flow cytometry showed percussor B cell ALL. How do you differentiate between lymphoblasts and myeloblasts? Dr. Sandeep?
Okay, so whenever we are doing a bone marrow and we are trying to differentiate different type of leukemia on morphology, the two most common leukemia that we see in pediatric population are acute lymphoblastic leukemia and acute myeloblastic leukemia. So in general, the lymphoblasts are smaller in size compared to myeloblasts. Lymphoblasts are around 15 micron and myeloblasts are around 20 micron. Then the nuclear size is much larger in lymphoblast, and you have very thin rim of cytoplasm in lymphoblast. In myeloblast, this cytoplasm is abundant as compared to lymphoblast. Then again, you can see the cytoplasmic granules and ore rods in myeloblast, which are absent in lymphoblast. So all this morphology is definitely very helpful, but in 10 to 15% of the patient, it may be difficult to differentiate even L2 blast from M1 AML blast. So definitely it gives us some clue, but I will definitely go for immunophenotyping to confirm the type of leukemia, because that is like essential to plan further treatment. So morphology is important, but subsequent investigations are also equally important.
So important thing is that today's world, the morphology is important, as Dr. Sandeep said, but more important than that also is the various investigations which you need to do, like immunophenotyping, cytochemistry, and other investigations, even molecular and cytogenetics, to come to a conclusion as to what we are dealing with. And gone are the days when I remember when I was a resident, the professors used to fight on the morphology, and daggers would be drawn for that, you know. So, but now things have become much more easy. It's like remembering our undergrad days when we had uh, people fighting over what kind of a murmur it is, and when you would do the echo, the probably the student would be correct and the professor would be wrong in the type of murmur which we were dealing with. This is not uncommon, but people would fail on the type of murmur which they described. Okay, let's move on. Would you? Yes, you have already answered that. Bone marrow biopsy is always needed and is supplementary to the diagnosis. It
Yeah.
tells us the diagnosis required when inadequate or failed aspiration, assessment of cellularity, assessment of bone marrow architecture, suspected focal lesions, for example, suspected granulomatous disease or lymphomas, and bone marrow fibrosis, which is commonly seen with acute megakaryocytic leukemia. What further investigations would you like to send from bone marrow aspirate, Dr. Sandeep?
So in addition to morphology that we have to see, we have to send sample for immunophenotyping. Immunophenotyping will be useful to categorize the type of leukemia, whether it is ALL or AML. Among the ALL also, we will have to know whether this is B or T subtype, because this will further help us in planning the treatment for this child. Then again, we need to send some karyotype, and because in today's time it is not just about the diagnosis that we get from the bone marrow, we have to characterize every child so as to have a accurate risk stratification. So in today's time, low risk patient actually may require a lesser treatment, and a high risk patient may require even bone marrow transplant. So in that case, this accurate risk stratification is key, and this is information that we get by cytogenetics and molecular studies. So molecular and karyotype studies are essential for accurate risk stratification, and that should be done without fail at the time of diagnosis. So even if we are dealing with a case of pancytopenia, we are not sure about the diagnosis. So that is why we need a bone marrow biopsy, because suppose this turns out to be a plastic anemia, then bone marrow biopsy was definitely required. And also, if it doesn't turn out to be leukemia, but still we have to take the sample for flow, molecular and cytogenetics, because we don't want to do this again. So all this is essential.
In a nutshell, what you're saying is that in case you have a patient of pancytopenia, draw all the samples, look at the
Yeah.
look at the bone marrow, aspirate, and then decide what to send and where to send. Because
Yeah.
you can't have a patient undergoing another aspirate just because you've not drawn the samples. You can discard the samples which are not needed, but please draw all the samples.
Right.
Uh, Sandeep, can you tell us briefly about the outcome of this condition in 2020?
So now this is B acute leukemia, B cell acute leukemia, lymphoblastic leukemia. Patient looks like standard risk. She was, I think, 4-year-old. She had pancytopenia. So at least with the information that we have so far, this looks like a standard risk acute lymphoblastic leukemia. Definitely response to treatment will be key to assign the definitive risk group. But so far she looks like a standard risk acute lymphoblastic leukemia, and prognosis of standard risk ALL in today's time is close to 90% if it is appropriately treated. So I think this is an important message, unlike few decades before where cancer was like a death warrant. Now this is highly curable. In fact, childhood acute lymphoblastic leukemia is a success story of the modern contemporary oncology. And it is often said that childhood leukemia has paved way for success of many other pediatric illnesses.
Would a figure of 90% be appropriate for India also, or is it appropriate for the Western world?
So we have to remember that India is just not one infrastructure kind of thing. We have centers where you have all state of the art facilities and every facility that you see in the North America or European country. But you may have certain centers in India which don't have like flow cytometry, which don't have accurate certification. So that kind of difference is always going to be there depending on where you are treating this child. But in a setup where all facilities are available, like in your setup or in my setup or in Dr. Yadav's setup, I think the results are close to 90%, no doubt about it. But in certain center where supportive care infrastructure may not be that good, so outcome may vary depending on many factors.
And what is the rough duration of the treatment? Dr. Vikas, would you like to comment upon the rough duration of the treatment of acute lymphoblastic leukemia B cell?
Yes, sir. So majority of patients who have got acute lymphoblastic leukemia, they need to be treated for around 2 to 3 years. And whether you treat these patients on American protocol, UK protocol, or Malaysia Singapore-based protocol, the duration is between 2 to 3 years. So the intensive part, I would say, for which the patient would be coming in and out to the hospital would be 6 to 8 months, and then he'll be requiring oral therapy for another 1.5 years.
Okay, audience question. How do we calculate corrected retic count? Corrected retic count, 4 possibilities is percentage retics. Sorry. There are 4 possibilities. Could you please mark out which one is the correct one?
Sir, we are halfway through the time.
Yeah.
We have done B12 folic acid. We have done acute leukemia. We are halfway through.
Okay. I think people have learned from Dr. Butt's lecture, as well as they must be knowing this very well because we've been reiterating it for years and years together. It's the packed cell volume, hematocrit patients, hematocrit divided by the expected hematocrit into the retic count, which gives us the corrected rate. Case 3 is a 10-year-old boy with persistent high-grade fever for 10 days, progressive lethargy, loss of appetite, bluish patches over the skin, sick-looking, febrile, pallor is present, petechiae over buccal mucosa, ecchymosis over lower limbs, no hepatosplenomegaly, no lymphadenopathy, no dysmorphism. And on investigations, hemoglobin was 7 grams, 390 was the TLC, platelets were 9,000, MCV was 82.3, RDW 12.1, neutrophils were just 23%, retic count was 1%, peripheral smear showed pancytopenia, no immature cells were seen. Dr. Yadav, what is your take on this?
So this child has got pancytopenia, and the retic count, which we look for the activity of the marrow. Whenever someone has all 3 cell lines affected, we think that it could be a bone marrow production defect, and we order a reticulocyte count to see the marrow activity. So here it is 1%. So usually 1% retic is normal. But if you have anemia like hemoglobin of 7, then we have to look at the corrected reticulocyte count. And if we see that corrected reticulocyte count here would be less than 1%, and that indicates that marrow is not appropriately, hasn't appropriately responded to the stress. When the hemoglobin is less, the marrow should increase. In fact, the retic should have been close to 2% here for a hemoglobin of 7, and it's not. So that indicates that marrow production is affected. The bone marrow is not working very well, and red cell production is definitely low. So it's likely to be a bone marrow defect, and we should do a marrow to see what is the defect likely is, to look at the cellularity and that whether it's a bone marrow failure syndrome. Thank you.
So we have already told you that it is the patient's PCV divided by the PCV expected at that age. The corrected retic count in this patient is 0.4%. How would you like to proceed in this case, Satya?
As I said that first we should order a peripheral smear always whenever someone has pancytopenia, to look for any abnormal cells like any leukemia cells visible there, and to see for the features of macrocytes that it could be a nutritional anemia, as we have discussed in the previous case. So these clues can be gathered from a good peripheral smear. And then a bone marrow is always required, where especially if the retic count is low, we are suspecting the bone marrow is not working very well. So we will do a bone marrow aspiration and bone marrow biopsy to look at the cellularity level and to be sure that this is bone marrow, whether this is hypocellular marrow aplastic anemia or not. So that would be confirmed, or myelodysplastic syndrome, MDS. So let's do a marrow and a biopsy and see what we get. Thank you.
The marrow report says it's a hypocellular marrow with scattered hemopoietic cells and predominance of lymphocytes and no abnormal cells, no blasts.
So this looks like this is a bone marrow failure syndrome or bone marrow failure state. So it is a aplastic anemia. Now we have to see whether it is severe aplastic anemia or very severe aplastic anemia. So that depends on the absolute neutrophil count, whether ANC is more than 500 or less than 500. That if it's more than 500, it's likely to be moderate aplastic anemia. But if it's less than that, it is severe. And if it's less than 200 absolute neutrophil count, it is likely to be very severe aplastic anemia. And retic count and bone marrow cellularity also has to be looked at to confirm that this is aplastic anemia. And then we have to rule out inherited bone marrow failure syndromes, because Fanconi anemia, Dyskeratosis congenita, or diamond black fan, or pure red cell aplasia. These are the various genetic disorders which may be present in the child, which may be the cause of this bone marrow failure. And they don't usually respond to the immunosuppressive therapy, which is a standard thing which we offer if we are not doing a transplant. Then immunosuppressive therapy is usually offered in children with aplastic anemia. Thank you.
Okay, it's important to supplement the aspirate with a biopsy also, because cellularity is best commented upon biopsy. It was a hypoplastic marrow with 15% cellularity. Fatty areas are seen. Fatty areas of hematopoiesis are seen. No abnormal cells were seen. How do you define? You've told us a little bit about it, but could you elaborate on how do you define aplastic anemia?
So as we said that the reticulocyte count, so if the retic is less than 50,000, so that's in favor of bone marrow not working very well. Here it was 0.4%, which is like close to 40,000. And if you have neutropenia, so as I said, if you have absolute neutrophil count less than 500, that goes in favor of severe aplastic anemia. And you have, in the biopsy, the cellularity should be less than 25%. So that goes in favor of aplastic anemia. If it is more than that, then it's not severe. It may be moderate aplastic anemia. So those things are important. And platelets less than 50,000 is also helpful, is one of the criteria to diagnose. Thank you.
Dr. Yadav has already told you that severe aplastic anemia is when there is bone marrow cellularity less than 25%, or if there is or 25 to 50% with less than 30% of hemopoietic region. The neutrophils should be less than 500, platelets less than 20,000, retics less than 2.2%. Very severe is even worse than that, and 2 out of the 3 of the following with neutrophils less than 200, platelets less than 20,000, energetics 20,000 20,000 or 0.2%. Non-severe aplastic anemia is when those who are not fulfilling the criteria for severe aplastic anemia or very severe aplastic. Now, you have this patient who's got aplastic anemia. How would you investigate this child with bone marrow aplasia? Dr. Vikas, could you please comment upon that?
So whenever we have a patient of aplastic anemia, it is very important to know whether it is a idiopathic aplastic anemia or it is an inherited bone marrow failure syndrome. So when you have a patient like this, we need to work up this patient on the lines that we need to we need to do chromosomal breakage study. And nowadays, next generation sequencing is also available, which can tell us whether this patient has got some other inherited bone marrow failure syndrome or not. Other than that, karyotyping, or you can say, I would say, cytogenetics is very important, because a picture like this can be seen in hypoplastic MDS. Though MDS is very uncommon in pediatric age group, but yes, it's very important to look at the cytogenetics. Then this might be a manifestation of PNH, paroxysmal nocturnal hemoglobinuria. That's why you need to work up on the lines of PNH also. And then you may be having a patient who's got aplastic anemia. The cause might be a viral infection like hepatitis B, hepatitis C, or HIV. You can work on those lines also. And once you confirm this patient to be having severe or very severe aplastic anemia, whether it is an acquired or an inherited form, it's very important to get your HLA typing done of the patient and sibling in the first group.
Okay, this is a chromosomal breakage study which shows triradiates and other, which is done with mitomycin C or diapoxybutane. And this is typically seen with Fanconi's anemia. What is the diagnosis which was seen in this case? What is the diagnosis in this case, Satya? Dr. Yadav? With the kind of chromosomal breakage study which you have, are you there? Okay, we move on.
Unmute, Dr. Yadav, unmute yourself.
Yeah, sorry, it's a Fanconi anemia. Sorry for that. Yeah, because of increased chromosome breakage seen on the test, this is highly suggestive that this child has Fanconi anemia. And this has a lot of implications on the further management of the child, because they don't respond to immunosuppressive therapy. So that treatment is out of question. You don't give ATG or cyclosporin to this child. This child needs a definitive treatment like a bone marrow transplant to cure this. And if transplant is not available or the child is not yet transfusion dependent, then can be closely monitored for some time until the child becomes transfusion dependent. Thank you.
You have already told us about the options for Fanconi's anemia. Usually anabolic steroids are used and hemopoietic stem cell transplant can be done in these patients. This is a patient of Fanconi's anemia who is now 3 years post HST and is absolutely fine. I think was from Ahmedabad. Children with Fanconi's anemia are known to have hematological abnormalities. Describe those briefly. Dr. Vikas, could you please describe those?
So these patients who have got Fanconi's anemia, they usually present to us with aplastic anemia. And other than that, the other hematological abnormalities which can happen to these patients is they can have leukemias, they can have I would say myelodysplastic syndromes, and sometimes just plain and simple macrocytosis can be seen, or an isolated cell line which has been affected, like low hemoglobin, that means anemia, or just mild to moderate thrombocytopenia can be seen in these patients.
Thank you. There are certain physical findings associated with Fanconi's anemia. I think we don't have to go into the details of those findings, but remember that only about 25 to 30% of the cases of Fanconi's anemia have a phenotype of a Fanconi anemia. So every patient of aplastic anemia or hypoplastic anemia must undergo a chromosomal breakage study, even if there are no physical findings. Audience question. Pancytopenia is not a common feature of PNH, diamond black fan anemia, Fanconi anemia, Schwarzman-Diamond syndrome. Can you have the audience poll? It seems to be quite evenly divided, except that Fanconi's anemia. But yes, diamond black fan syndrome usually does not have pancytopenia as a feature. Okay, 8-year-old boy with pancytopenia, bone marrow aplasia, chromosomal breakage was negative. How is the management of this child different from the previous one? Satya, would you please like to comment?
Yeah. So as we have discussed previously, that whenever a child is diagnosed with aplastic anemia, and we have to rule out inherited bone marrow failure syndrome. So if the child doesn't have any skeletal anomalies, chromosome breakage study is normal, this doesn't have any features of Dyskeratosis, Congenita and other things, then it is likely that this child has acquired aplastic anemia. And in such a scenario, the treatment modalities are a matched sibling donor bone marrow transplant. If he has a healthy brother or sister who's a full HLA matched donor, then we should do a bone marrow transplant, which has success rate of more than 90%. And if that is not available, then immunosuppressive therapy with antithymoglobulin and cyclosporin can be offered. And that has a success rate between, say, about 50 to 70% in various centers with different kinds of results. So these are the two treatment options we have in this child. Thank you.
So this is the outcome of aplastic anemia in a study of severe aplastic anemia. As you can see, HSCT is nearly 90%, whereas IST is around 50 to 60% or so. This is again a patient of severe aplastic anemia who underwent a matched unrelated donor transplant of her IST and is doing absolutely fine. Audience question: 10-year-old boy with hypocellular marrow has following features. What, as shown in the pictures, what is the likely diagnosis? Fanconi's anemia, diamond black fan, Dyskeratosis congenita, and Schwartzman-Diamond syndrome. Okay, practically everybody has answered it very well, and that is Dyskeratosis congenita. And as you can see, there is nail dystrophy, there are reticulated pigmentation, and there are areas of tongue involvement also. Okay, case 5 is a 3-month-old boy born out of non-consanguineous marriage, was referred from a hospital at North Delhi, fever 1 month, mild cough for 7 days, birth history, term vaginal, birth weight was 2.9 kg, developmental history was normal, immunization received till 1.5 months of age. On examination, dull looking, pallor was present, liver was 5 centimeters below costal margin, spleen was 5 centimeters below costal margin. CBC showed hemoglobin of 8, 18,000 count, 90,000 platelets, neutrophils of 12%, lymphocytes of 76%, MCV, RDW within the normal range, toxic granules, many reactive lymphocyte, lymphomonocytoid cells, LFT was SGOT, PT 480, 500, and bilirubin was 1.2. Blood culture was sterile, urine culture was sterile, malaria antigen is negative. HPLC was normal. Fundus for cherry red spot was negative. Course of illness was started on IV antibiotics, call from lab. Highly lipemic sample was seen. Persistent fever. Torch profile was evaded. I think I'll request Dr. Yadav to answer this question because I remember seeing so many patients with him when he was with us with a lipemic serum, and we used to wonder what it could be and why is it happening.
Yeah. So this, thank you, sir. This is definitely, first of all, it's a very, very sick child. So whenever a child is running, a small child running very high grade fever with big liver and spleen, with pancytopenia, and with deranged LFT, this tells you that this child has got something seriously wrong with him, and needs urgent investigations to diagnose, so that we can start appropriate treatment. So we live in India, and infections are very, very common. So we always think when someone comes with fever and pancytopenia, we think that this could be some sort of infection which is causing all this. That's true that it can be infection, it can be a malignancy, it can be so many etiologies which can lead to this. But one thing we have to rule out is that has this child got hemophagocytosis, lymphohistiocytosis? So that is HLH. Because with HLH, you can die within, say, a couple of days. And for that, a simple test is serum ferritin, which should be ordered quickly whenever a sick child comes with pancytopenia. And if serum ferritin is high, like 5,000 or more, then it gives you a big hint that this could be HLH. So I would order a serum ferritin here quickly. And if that is high, usually more than 500 is high. And a lipemic serum, what the lab is telling you, ask them to run a sample to see the level of triglycerides. And usually triglyceride levels are very high in HLH, and that might be the case in this child. So high, there are about 8 criteria. Out of them, at least 5 should be positive to diagnose HLH. So a persistent high-grade fever is one of the criteria which is present here in this child. Then the second is bicytopenia or pancytopenia, which is a diagnostic criteria which is present here. Third is that presence of splenomegaly is a diagnostic criteria which is present here. And fourth is high triglyceride levels, which is likely because of lipemic serum here. So possibly he already has 4 features which are in favor of HLH. And fifth one could be a serum ferritin. If we order, that would be high. We can order an IL-2R levels, interleukin 2 receptor levels, which are usually high, but they are not available in all the labs. And we can do a bone marrow to look for hemophagocytosis, and that would be another criteria which could help confirm this entity in this child. And a deranged LFT is always in favor of HLH, which is already present here. Thank you.
Okay, the ferritin was 6,499, triglyceride 673, fibrinogen was markedly low. There was serum IL-2R was 2,800, should be below 2,400. So this was typically what we saw in the marrow also, which shows a hemophagocytosis in this patient. So the diagnosis was HLH was made, and the child was started on dexamethasone. Would you like to investigate the child further, find out the etiology? Dr. Vikas, would you like to answer this?
So we need to understand that acquired HLH can be because of infection, which Dr. Yadav has already pointed out. So it could be a bacterial infection, a viral infection, a fungal infection. So any infection can trigger HLH. Other than infections, we need to understand that malignancy or an autoimmune disorder can trigger HLH. So we would like to investigate this case. We would do a blood culture. We will look for viral infections like EBV, which is the most common cause of HLH. We would look for CMV, some other viral infections, a hepatitis B, C, HIV, and along with that, ANA, double-stranded DNA. And if it's a malignancy like leukemia, you may see evidence of blast in the bone marrow.
Okay, since this child was very small, was an infant, rather a neonate, we did all these, we did the torch, we saw the CMV, it was 82,170 copies. EBV PCR was normal, immunoglobulin profile was normal, lymphocyte subsets were normal. So this child was CMV triggered HLH, and he was started on ganciclovir followed by oral Valgan. Would you like the child to be investigated for familial HLH mutations, Vikas?
As this is a small boy, sir, so we should actually investigate these small babies, and we should do workup for familial HLH in these cases.
We did investigate and we found UNC1 mutation, which proved that this patient had a familial HLH. Now, what step would you take now? The child has become better. The child has responded very well to ganciclovir and valganciclovir. Is growing well. What step would you like to take further?
So if it's a familial HLH, definitely the patient would need a transplant. But if you don't find evidence of if you don't find a genetic issue in this case, then you should treat these patients with immunosuppressive therapies like dexamethasone, etoposide, and you may add cyclosporin to these patients. And definitely, you need to treat the underlying trigger. Like in this case, as ganciclovir was started, so along with ganciclovir, you may have to add immunosuppressive therapy.
Well, this was the only child, and we followed it up with clinical observation after treating with dexamethasone and galcycline. And 1 year post that episode, no recurrence of HLH has occurred. If further recurrence of HLH occurs, we would certainly consider him for an HSCT, even if it may be a haplo or a MUD. Case 6, a 6-week-old child, old girl with persistent high-grade fever for 10 days. On examination, had tachycardia, tachypnea, SpO2 at room was 93%. Pallor, liver, spleen, both were 5 centimeters each. Started on oxygen with nasal prongs, 12.7 hemoglobin, 6,550 counts, 70,000 platelets, neutrophils of just 16% with atypical lymphocytes, 12%. Workup for dengue, malaria, torch negative, CRP high, LFT transaminitis was seen, blood culture was sterile, chest X-ray normal, urine culture was sterile. Started on IV antibiotics, worsening respiratory distress, started on high flow nasal catheter, worsening of liver enzymes, falling platelet counts, deranged coagulation profile, IV antibiotics were upgraded. Child was not showing any satisfactory improvement. Then the child was shifted to Gangaram Hospital with the hemoglobin of 6.4, 3,270 count, 48,000 platelets, and neutrophils of 15, and lymphocytes of 77%. Ferritin was 90,040, triglycerides of 504, fibrinogen 0.60, serum IL2R was 8,000. So no rocket science, this was an HLH. Okay. Now we go further. This was the bone marrow, and again it is showing hemophagocytosis. IgG profile, lymphocyte subsets were normal, started on dexamethasone, supportive care, and improved gradually. The child was had perforin mutation, and how will you manage this patient, Dr. Vikas?
So we need to start these patients on HLH 2004 protocol, which says that you have to give these patients immunosuppressive therapy like dexamethasone, cyclosporin, and etoposide. And as this is a case of familial HLH, once you are able to control the hyperinflammation, which usually takes 8 weeks, then you should proceed and go ahead with transplants. I would say bone marrow transplant in these kind of cases.
So if we don't do a transplant and we don't give massive immunosuppression, this patient has very little chances of a survival. Audience question. Absolute neutrophil count includes segmented neutrophils only, band forms only, segmented neutrophils plus band form, or segmented neutrophils minus band forms. And we've all answered correctly, and that is it includes both ANC plus segmented neutrophils with band forms. Can you? Okay, 10-year-old girl presented with perianal abscess. She was admitted with a pneumonia 2 years back. She needed hospitalization for 2 weeks. She has past history of UTI 4 years back. There is history of recurrent oral ulcers and other minor infections. What, when do you investigate a child for suspected immunodeficiency, and what are the basic investigations? I won't go into the details, but 10 warning signs are there of primary immunodeficiency. If you have 4 or more new ear infections within 1 year, 2 or more serious sinus infections within 1 year, 2 or more months on antibiotics with a little effect, 2 or more pneumonias within 1 year, failure of an infant to gain weight or grow normally, recurrent deep skin or organ abscesses, persistent thrush in mouth or fungal infection, need for intravenous antibiotics to clear infections, 2 or more deep-seated infections, including septicemia, and a family history of immunodeficiency or a sibling death unexplained is what I would look for in these patients. Basic investigation profile is CBC, HIV ELISA, immunoglobulin profile, the various subsets of T and B cells, NBT, DHR, and a flow cytometry for leukocyte adhesion defect. Now, how does a CBC help in diagnosing immunodeficiency disorder? Dr. Satya.
Yeah, so thank you, sir. So CBC is a very simple test, and it can always be very, very helpful in a suspected case of immunodeficiency. So you should look at all the cell lines first. So if there is pancytopenia like TLC, HB, and platelets, everything is low, and child has recurrent infections, other than malignancy and other causes, and HLH, etc., you should also think of reticular dysgenesis, where there is pancytopenia and you have severe lymphopenia and combined immunodeficiency is present. If the counts are normal, there is no pancytopenia, and you still have recurrent infections, then you look at the kind of infections you are getting, whether they are mainly viral infections, fungal infections, or they are mainly bacterial infections. So if it's just mainly viral infections and oral candidiasis, etc., then it's a cellular defect, T cell defect is more likely. And if there is more bacterial infections, then it is likely to be a humoral defect where B cells or immunoglobulin levels might be low, and that might be causing, or neutrophils may not be working very well. That may be the cause of infection. So here this child is having recurrent perianal abscess and UTIs and I think pneumonia. So they all are indicating that it could be bacterial infection is the main problem in this child, which indicates that this child might be having either immunoglobulins or B cell defect, or maybe a neutrophil defect. The neutrophils are not working very well. So accordingly, we will try to investigate and look at that. In the CBC, you can look at the neutropenia if it's present. That would give you a hint. If there is lymphopenia in the CBC, that would also give you a hint that it could be a cellular or T cell defect if the lymphopenia is severe, like less than 300 absolute lymphocyte count. And if neutrophils are less than 1500 absolute neutropenia, that would have indicated that this could be a neutropenia, which may be the cause of neutrophil defect. And if they are all normal, then it could be something like chronic granulomatous disease, which can be diagnosed by dihydrorhodamine test on flow cytometry, or it could be a leukocyte adhesion defect where your white cell count are extraordinarily high, like 30,000-40,000 persistently on repeated occasions. Every time your TLC is very high, and these child might be having leukocyte adhesion defect. Thank you.
Just hello. Okay, the hemogram of this patient had TLC of just 3,400 with neutrophils of just 3% or 5%, and this was a patient with neutropenia. What is the next investigation you would like to do in this patient? Dr. Vikas, would you?
So, sir, we should do a bone marrow test in a patient who has got neutropenia and we are suspecting it to be a immunodeficiency. So, like in this case, what we are seeing is a maturation defect. So, you may be having a problem, something like called congenital. Because of that, you are seeing a less number of neutrophils in the peripheral circulation, and this patient is having a bacterial infection.
So this patient had a neutropenia and ELAN defect was seen in this patient. I think we'll just go on to the next one. A recent patient who presented to us with recurrent infections, there was a documented neutropenia in 10 to 12 CBCs, multiple hospitalizations for the last 4 years, and clubbing was present, as you can see. And this was the picture in the patient, in this thing. Dr. Sandeep, would you like to comment upon the differences between severe congenital neutropenia and a cyclical neutropenia? Sandeep, are you there?
Sandeep, can
Yes,
you
okay,
unmute?
yes, I can hear. Okay, in severe congenital neutropenia, you have low neutrophil count throughout, but in cyclic neutropenia, there may be a trend where you may have normal neutrophil count and then it dips down and then it may become normal. So it's a cyclic in nature. And then the severity of neutropenia is somewhat more in congenital form, and it is somewhat milder in the cyclic neutropenia. And also chances of its malignant transformation to AML or MDS is much more in congenital neutropenia, and it is quite low when it is in the cyclic neutropenia. So these are the major differences. And the treatment, from treatment point of view, severe congenital neutropenia requires like growth factor. And this growth factor, initially you may start maybe at daily, but later on with looking at the ANC and response, then you can drop it down to maybe alternate day and then maybe even once or twice weekly. And in cyclic neutropenia also, if neutrophil count is low and during the period of neutropenia, you can supplement with the growth factor.
So this is classically the picture of a cyclical neutropenia when you see the plot the neutrophil count and the total TLC, and this is the picture in a congenital neutropenia where the TLC goes up and down, but the neutrophils are flat, totally flat in these cases. So medicine never ceases to amaze you. And for the audience, a 15-year-old girl from Firozabad referred with bilateral joint pains, breathlessness, multiple necrotic skin lesions, and intermittent fever for 6 months. On examination, she had maculopapular lesions, hepatosplenomegaly, and this was her condition, with involvement of the feet and rashes, and the face was swollen, and there was a huge swelling in the jaw. And clinical diagnosis of lupus was considered. Hemoglobin was 8.5, counts were just 2,220, platelets were 1,80,000. Myelocytes were 1%, neutrophils were 85%, lymphocytes were 0.8%, with monocytes 6%. She had a mild increase in BUN creatinine, OTPT, albumin was low, ESR was 87. And on the biopsy of the region, what did we find? We found histoplasmosis of the skin, bone marrow, and blood. No evidence of any malignancy was seen. I've never seen such a florid histoplasmosis in any patient whom we did not have any immunodeficiency disorder. So it never ceases. So careful examination, history, CBC, peripheral smear, and retic count form the basis of evaluating pancytopenia. Bone marrow biopsy must to rule out aplastic anemia. Rule out inherited bone marrow failure in all cases of aplasia. HLH is a medical emergency and a difficult disease to treat. Early referral in cases of pancytopenia improves the outcomes and helps the patient by decreasing the transfusion and blood component load also. Thank you.
Thank you, sir, and thank you all the panelists for the presentation. We discussed megaloblastic anemia, we discussed aplastic anemia, We discussed all the other DDs of pancytopenia or other cytopenias that come in the pediatric practice. We looked at inherited bone marrow failure syndrome. We looked at leukemia presenting as pancytopenia, and HLH, which is a new kid in the block. And we have been seeing so many cases of HLH, either induced by viruses or induced by typhoid or other kind of infections which are leading to HLH. So thank you so much for an exhaustive presentation, sir. Now we have some questions which are there in the group. Some are there in the WhatsApp group and some are there in the Q&A session. So if you all could please answer those questions. I think Sunil is also here and we can take them one by one. The most important question that is being featuring again and again is about how we treat B12 deficiency. So what regimen is followed? I think this is a confusing thing for all of us. How do we treat B12 deficiency, sir?
Sunil, would you like to answer that? Sunil?
So maybe
can you hear me?
Maybe you can answer, sir. Dr. Anupam, maybe you can answer. Or...
Okay.
Sorry, I was typing something.
Okay. Yes, Sunil, can you tell the audience how to treat B12 deficiency?
Yeah, so I think, can you hear me?
Yes,
yeah.
We can hear you.
Yeah, I think sir is probably the right person to answer it, but I just put a little perspective why it's very confusing. Because I think vitamin B12 deficiency comes predominantly, the treatment which I've been reading in Nelson and otherwise comes from the Western literature, where the most common cause for vitamin B12 deficiency for them is pernicious anemia. And pernicious anemia, we know, is a lifelong problem. So they need to be on vitamin B12 replacement lifelong. Now, what we were discussing and what we are dealing with here most commonly is a nutritional vitamin B12 deficiency. So, that's why I think there's a little of confusion in how to treat them. So what we usually do for nutritional deficiency is that we would give them weekly B12, most probably parenteral 1 milligram dose for 4 weeks, and then we'll ensure that they're having a decent diet which is rich in vitamin B12, which may be sometimes a challenge in those who are purely vegetarian diet people. Now, this is my practice, that if children after this are having a recurrence of their vitamin B12 deficiencies after you restored their stores and they're still having problems, then those are the ones who will require a workup of pernicious anemia. And that's one of the questions also put in the group, that would always do that as a part of their treatment. So that is how I approach it. But I don't know what sir wants to say. It's probably the most experienced among us. Deficiencies.
People have recommended intramuscular vitamin B12 1 milligram for 4 to 6 weeks. But my experience is that once you give them an IV 1 milligram B12, it's enough to saturate the body. And then you can follow it up with oral methabol or methylcobalamin, which is fairly good. But be very careful, because once you have started them on oral, there should not be any malabsorption or other things. And you have to clearly follow up. You don't have to give so many injections of B12. And remember this thing, that B12 is usually comes with thrombocytopenia also. It may not be that feasible to give intramuscular B12 in these patients.
I think the newer evidence is pointing towards a lot of oral usage of B12 and a lot of a good outcome with oral B12. I think there was a study published from GTB which showed that giving 1000 microgram of B12 every day orally for 2 weeks, I think helps in hematopoiesis, and then I think they gave weekly doses of 1000 micrograms. So lots and lots of regimen use something, and most of the time we'll have a benefit. Is there a different dose for young children? Anybody would comment? Young children. Sandeep wants to comment this. Yes,
Manas, I think Dr. Jagdish Chandra has done lots of studies on megaloblastic anemia
so
and B12.
Dr. Gombar as well. Yeah.
And they have shown that oral is as effective as parenteral.
So that's what I said. I think the whole discussion of parenteral had come from pernicious anemia background. And
Yeah.
we have been reading all those papers, and so I think we deal with a different population. So our oral administration should be good enough.
And what Dr. Chandra has been using is like 250 microgram for less than 2 years of age. 2 to 10 years they were using like 500, and 10 years they were using
1000 microgram of B12. And most of the patients responded very well. So that's the
you just have to make sure they are not having chronic diarrhea, there is no malabsorption, and if there is inappropriate response, then only they give the parenteral one. Otherwise you can very well go with the oral one.
Absolutely.
Sir, the next question, Dr. Anupam, this is for you. The question is treatment option for infection associated HLH. There is always this confusion between infection associated HLH or primary HLH. So you have a HLH like situation and the patient has infection associated HLH. Would you be worried about giving steroids to this patient, or would you just give steroids if he has a florid HLH?
Okay, that's a very big dilemma now. We have recently sent for publication our series on HLH of about 120 odd patients. And the key thing is that if you have an infection, treat the infection vigorously. And in case the patient is not responding, start with dexamethasone. You can use IVIG in these cases also, because you can use it in immunomodulatory this thing. Start with dexamethasone, and in higher doses, we are dealing with a serious condition, and I wouldn't be scared of using dexamethasone in this condition. In fact, in our study, we have shown that if you institute dexamethasone with etoposide earlier on, the results are much better than if they are instituted later. So that is what the difference between SIRS and MODS and HLH is, that I would shudder to use dexamethasone and etoposide in patients with SIRS and MODS, but certainly in HLH we would use them. Another issue which is there is that majority of these sick patients also present with CNS problems. And if they have CNS problems and it is HLH induced, then the treatment is to use intrathecal methotrexate with steroids, which again we would seriously not consider in a patient of just sepsis. So it's important that we investigate the patient for HLH and institute the treatment ASAP if the patient is not responding to your usual antibiotics.
Dr. Yadav, this question is for you. That we have seen in dengue, typhoid with secondary HLH recovered with dexamethasone. Do we need to do a familial HLH mutation for all these patients? So you are muted.
Yeah, so great question, Manas. I just had a case just last week where an infant came, a 5-month-old baby who was gasping in our ICU and was running very high-grade fever, diagnosed with HLH, and dengue was confirmed that the child had dengue. So dengue has already started in this season. And then we gave dexamethasone to treat the HLH and rest as per the dengue protocol. Child has recovered, doing very well. And the question was, because he was an infant, that should we screen him for familial HLH? So we have recommended, because he's very young, it's likely that if he has underlying familial mutation, that he would again have HLH. So I've ordered investigation for him. But if it's a bigger child, like 4 or 5-year-old, then familial HLH is less likely or unlikely. So I won't recommend the mutation or genetic testing in a bigger child more than 5-year-old. But younger children who come with severe HLH or very sick, very high ferritin levels, I may recommend investigations. That's what I would do. Thank you.
Yes, sir.
Can I just comment one more thing?
Yes, sir.
It's not that familial HLH will present only at 1 or 2 years of age. I've seen a 58-year-old person who presented with sepsis and went into HLH and then was not getting control. So we, out of desperation, we sent the HLH, mutations, and we found that he was positive. And this has been very well documented that HLH can present, even familial HLH can present later on in life also. But yes, I would tend to agree with Satya that for the time being, we should limit ourselves to those patients who are below 2 years of age and have presented with HLH rather than going gung-ho on investigating them further.
So I think, sir, a lot of pediatricians have that impression that HLH is something which it's not common. We don't see it. It is a rare disease. And this has to be managed by hematologist, or, it has to be just referred to them. But I think, and I want to emphasize this for all our fellow colleague pediatricians, that this is an illness that we are seeing most commonly now. I think one of the most common indication for referral to us is becoming HLH. Every sick child in your ICU, be very careful that, is the reason for him becoming sick is HLH. He may not need a hematology oriented treatment, but, he might have to just have that high index of suspicion, and that exact value of ferritin is important. Some of the labs just give a value of more than 500. This more than 500 ferritin can be 50,000, or it can be just 1,000. So, there is a lot of difference. And I think that is something which we all should know. Sir, the next question is on
Can I just add on to that what you have said?
Yes, sir. Yes, sir.
If you remember your resident days, and everybody would remember that
Yes,
we used to have sick patients with sepsis going into icterus, going into renal failure, and then having convulsions and not surviving at all.
Yes.
In fact, we used to say these patients are not going to survive because they've got multi-organ kind of a...
We would call them multi-organ, yes.
We've got them multi-organ. These are the patients which were all probably HLH, or majority would be HLH. And if treated with high dose of dexamethasone and with other immunosuppressive drugs, we could probably salvage at least 50 to 60% of them. So it's very important that we have to put things in perspective. And I always call that, is HLH old wine in a new bottle? Old wine in the form of Sirs mods in a new bottle of HLH.
So the next question is about a neonate who has low neutrophil count. Sandeep, would you like to answer this? If a newborn has a low neutrophil count but is otherwise well, incidental finding of neutropenia, would you worry about this neutropenia in a newborn?
So first and foremost thing is you should know age appropriate cutoff to say it is neutropenia, because neonates generally have lymphocytosis. So 60, 70, even 75% of lymphocyte is normal in a neonate. So you have to see the nomogram and you have to make sure that it is actually neutropenia. That is the first and foremost thing. Then if it is really neutropenia and child is absolutely well, maybe I can observe him and may do it again 2 weeks later and see if the trend is persisting. If this is like severe neutropenia and it is persisting, then probably I may need a marrow for this patient.
Yes. So most of the time it is age appropriate and we should not worry about that neutropenia, and we can observe. I'll just take the last question, which is anybody can take this question. I think maybe Vikas is there or Sunil is there. As intensivists, lot of us prefer to treat infection associated HLH as a separate entity we now call as hyperferritinemic sepsis. There is a risk stratification defined for it, and usually steroids, methylprednisolone and not dexamethasone, and IVIG is preferred. If there are risk factors, then plasma exchange is recommended. We see this a lot in dengue. What is your opinion? So I think, it's probably the same thing with a different kind of a terminology. So high ferritin, sick child, maybe dengue triggered, and they want to give methylpred and IVIG, and maybe try a plasma exchange. So, would you like to comment on this? Sunil, would you like to comment, or Vikas?
So, so as you said, I think it's different names for the same entity, whether it's HLH or it's a macrophage activation syndrome or a hyperferritinemic sepsis. I think it's a spectrum of the same disease, wherein you have initial insult or initial trigger, which leads to inflammatory cascade, activation, and and resulting in some kind of hemophagocytosis and other immune changes. So I think the principles of the treatment remain the same. We discussed familial in a little bit more detail. So familial is a little different basket, but if there is there's a known trigger, we would the treatment would remain identification of the trigger and treating the appropriate trigger which has triggered it. So if it's an infection or dengue or or EBV or whatever has triggered it, so to treat that, and also somehow dampen the effect of immune reactivation. And that's very important. Whether you do with methylprednisolone, like for example, in macrophage activation syndrome, they use a high dose of methylprednisolone. In their ICU settings, they use methylprednisolone. And we, hematologists prefer to use dexamethasone. So whatever you use, that's the important aspect is to dampen that immune reactivation which has happened with one of the treatments, and which can be any of the steroids, whatever you choose based on the setting. But having said that, as we know, the HLH treatments from our HLH protocols, which were basically predominantly designed for familial HLHs, where steroid, etoposide are the backbone, and plus minus cyclosporin used to the backbone of treatment. But that necessarily may not be true in the pure secondary HLHs like dengue-associated HLHs or EB-associated HLHs and other infection HLHs, where probably your immune reactivation can be dampened only by a steroid, and that can most of the time that does the job. You may not necessarily add etoposide to the cocktail, which you otherwise do for a familial HLH. So I take the point. It's as I said, it's dealing with the problem in different ways, and you treat the primary cause and dampen the immune reactivation with a steroid, which can be methylprednisolone or dexamethasone.
Okay,
IVIG is helpful,
I think
but I'm not very sure about
Manas, I think we
plasmapheresis
need
as one of the modalities. I'm not sure about that. Sorry. Yeah, Vikas?
Vikas, yes.
yeah, Manas, I think for the pediatricians, it is very important for them to understand that this is a hyperinflammatory state. So what Sunil is saying is hyperinflammation, you can use either of the steroids. So you can use dexamethasone or methylprednisolone.
My only problem with using methylpred is that it has a significant mineralocorticoid effect, which is not seen with dexamethasone. So you have more of sodium problems with methylpred than with dexamethasone. The other advantage of dexamethasone is its penetration into the CNS, which may help in those cases where there is CNS HLH. So, that's why I prefer using dexamethasone or methylpred in these cases. There is definite role of IVIG, especially in patients who have infections, because it will help both ways. A little bit for the infections, and the other is immunomodulatory effect. Thank you.
So, Dr. Dinesh, I think we have already answered more than 50 questions, whether in the typed form or in the oral format. I understand that pancytopenia is sometimes difficult, and when diagnosed, the pediatrician would want to immediately refer to a hematologist. But as you see many times, with a partnership of a pediatrician, hematologist can deliver the best possible treatment for a child with pancytopenia. Whether you would like to now comment on anything.
Thank you, Dr. Manas, and thank you, Dr. Anupam sir, and all the panelists for such a nice and crisp presentations. I think all the attendees liked it very well. Now we have covered almost 75% of the journey from becoming in between from general pediatrician to hematologist. We will be in between somewhere, and tomorrow will be a great session with cord blood banking, which is very important subject, and the miscellaneous hematology. So tomorrow we'll be meeting at 2:30 p.m. Thank you very much.
Thank you very much.
Thank you.
Thank you.
Thank you, Manas. Thank you.
Thank you, everyone.
Thank you, Dr. Lalit. Thank you, Dr. Tomar.
Thank you, sir.
And pleasure meeting Satya, Sunil, Vikas, and Sandeep. pleasure meeting you all.
Thank you, sir. Same here.
Thank you, sir. Same here, sir.
Thank you, sir.
Thank you, Dr. Shalini. Thank you.
Thank you.
I
Bye-bye.
must not forget Shalini. All of you probably don't know, but Shalini worked with us as a senior registrar in Gangaram. So this
Dr. Satya ko I can recognize, but probably he was going to Australia that time. तो शायद वो नहीं जानते होंगे. But
I
I
know you.
remember
I
him.
know you, Shalini. Yes, I know you. Thank you so much.
So,
Thank you, sir.
like the Gangaram family really well. Thank you.
Thank you, sir. Thank you.
Thank you. Thank you, sir.